Okay, so this is part B of the defense mechanism lecture. So the first half, we covered the basic concepts in the Freudian issues with the psyche and what the defense mechanisms were and so forth, and then we also covered the narcissistic defenses. So in this chunk, we're going to start out by talking about the immature defense mechanisms. Okay, so just to jump in here, one of the things that we see. Oh, hold on. I guess there's just a little bit more here that we need to deal with in terms of the narcissistic. Okay. Remember, once again, I told you there would be certain psychiatric disorders that you needed to understand are associated with certain defense mechanisms. So if you have somebody with borderline personality disorder, okay, they're oftentimes associated with this idea of splitting. So the borderline personality disorder individual tends to also see the world in all good or all bad. All right, and similar almost to the narcissistic personality disorder, they're very pleasant individuals so long as they see you in the all good category. But when they decide to place you in the all bad category, then they're just done with you. They'll say terrible things about you. They'll shred you to pieces on Facebook and things like that, and they'll try to turn the world against you. So that's another one of the psychiatric disorders that are associated with it. Okay. One more quick discussion here. Prejudice and stereotypes are a way of splitting. So, saying all Pacific Islanders are slow and dumb and coming from a village, all right, that's a prejudice. That's a stereotype that a lot of people outside of the Pacific hold towards individuals from the Pacific. So in other words, they've placed everybody into an all bad category. Or another example might be, everybody loves Hawaii. Everybody wants to go and spend time in Hawaii. And sure, the beaches are great. Waikiki is a beautiful place. And if you're there on vacation, it's a great place to be. But for individuals that live there are areas that are just have a lot of problems with social unrest, with poverty, with violent crimes and stuff. And so simply saying that everything about Hawaii is good would also be an example of splitting there. Okay. All right, so that kind of wraps up the narcissistic defense mechanism. So we had projection, we had denial, and we had splitting. All right, so our second cluster that we're going to talk about are the immature defense mechanisms. Now, despite the name immature, the theory would be, since we're working our way up the transcendency of the defense mechanisms here, is that the use of the immature defenses would be for somebody who's a bit more evolved than someone who relies primarily on the narcissistic defense mechanisms. Okay, so of the immature, all right, what do we have? We've got four main types that we need to talk about. Okay, we've got blocking, regression, somatization, and introjection. The other term for introjection we sometimes use is identification. Okay. Now, blocking to an extent is not truly a defense mechanism, but we tend to lump it here anyway. Blocking is a transient, or transient simply means a temporary blockage in your ability to think about or remember a specific event. You have experienced this. You have gone in and you have taken an exam, and you reached a certain point in the exam where they asked you for some information. And you studied the information, and the information is there in your brain, but you just can't seem to get it out. All right, these are those situations where we say it was on the tip of my tongue. That's blocking. And what happens? You walk out of the exam, and lo and behold, 30 seconds after walking out the door, you go, oh, that's right, that's the information. All right, so why do we consider blocking a defense mechanism? There we go. The example I have, a student who cannot recall the name of a muscle during their anatomy exam, but recalls it as soon as she leaves the exam center. So why do we call it a defense mechanism? Because it's essentially a way of dealing with anxiety. All right, maybe you didn't study the information quite as well as you should have. All right, and once you leave the exam and the stress of the exam is removed, then the information comes back to you a little bit more readily. The other reason we call it a defense mechanism is it's an embarrassment to you. All right, and so it does cause you emotional distress that you have to find a way to deal with. Okay. You've seen me do this one in class. I'll be rambling on about something, and all of a sudden I'll say, now what was the point of this? Why was I giving you this information? That's an example of blocking. A dentist, you might be looking at somebody one day and go, well, it appears from your x-rays and your pathology reports that you're suffering from, I can't remember what you're suffering from. Okay, like I said, it's embarrassing. All right, it's similar to the defense mechanism of a repression. All right, and we'll talk about that just in a minute, so don't worry so much about that, okay? We already mentioned this already. It's disruptive to social situations. It causes you anxiety because you're afraid that you might forget something in public and you might make a fool of yourself, or you might forget something on an exam and you feel like a fool in front of your classmates or your peers, okay? All right, let's move on. So the second of the immature defenses that we need to talk about is regression, all right? Refers to returning to an earlier stage of development in response to an anxiety or fear. So in other words, this is the individual who acts like a child in response to some type of bad news or some type of a stressful situation, okay? So in other words, they act younger than they are. Why would they do that? Well, if you are receiving bad news. You're receiving news that maybe a family member has died, and emotionally you just can't deal with that. Well, you can start acting like a child. All right, you can start because nobody is going to expect a child to deal with the reality of the death of a loved one or the death or a diagnosis of a terminal illness. So instead of directly confronting the emotions associated with the negativity, you simply act like a child, and that's a way of not having to confront those emotions. Okay? Here's some examples. An older patient giggles uncontrollably or breaks down crying when he's told bad news. Okay. Husband speaks to his wife in baby talk when she confronts him about a gambling habit. All right. Doesn't want to talk about his gambling habit. So nobody expects a child to have a gambling habit. I'll simply regress to an earlier developmental stage to avoid confronting the news. A patient lies in bed curled into the fetal position when it's time to go to surgery. Okay. So like I said, it's a response to a situation which requires a reaction that would be appropriate for the person's age. All right. In other words, act like an adult. All right. But they don't want to have to deal with that. We expect adults to deal with bad news head on. So you regress to an earlier stage. You don't have to deal with or accept the situation. Okay. Regression, when is it normal? Regression is actually very normal. Think about playing with a child. You know, maybe you have a niece or a nephew, or maybe you were the older sibling in a family, something along those lines. And when you play with a child, you act like a child. All right. When I play with Parker at home, I tend to act like a 3-year-old. Okay. That's a form of regression that is actually normal. It allows us to regress to an earlier developmental stage in which we can act in an appropriate manner with the child. Okay. Sleeping is actually a form of regression because if you think about it, when you go to sleep, you're allowing your body to relax. All right. You're putting aside the normal tendency that we have as human beings to protect ourselves and our surroundings. You let all that go and you place yourself in a very vulnerable childlike position when you go to sleep. Relaxing is a form of regression as well. Okay? All right, moving on here. All right, so in other words, it's common in children as well as adults. All right. Here's a wonderful example of this. You can take a child who is potty trained. Okay, and they seem to have broken the habit of needing to wear diapers or needing to wear pull-ups or whatever it happens to be at night, and they're perfectly trained. Well, lo and behold, all of a sudden you wake up one day and they're wetting the bed at night. All right. Why? Why is the child suddenly gone from being toilet trained to wetting the bed at night? Well, it could be that there's some type of stressful situation in the home. Maybe dad is getting transferred and you're picking up and you're moving and the child has to deal with the emotions of leaving friends behind. And he doesn't want to be told, oh, be a big boy. Deal with this. All right. So psychologically, the child regresses to an earlier age, begins to wet the bed again. Why? Because if the child's at the age where they're wetting the bed, we don't expect them to deal with the adult situations that they're being faced with. Okay. All right. So our third type of immature defense mechanism that we need to talk about is somatization. Okay. Soma is Latin for simply referring to the body. Okay, so in somatization, basically what you're going to do is you're going to take psychological symptoms, or what I call here psychic derivatives. Okay, simply put, it's the stress, it's the anxiety associated with things that are going around you. All right, so these are the butterflies that maybe you feel in your stomach. So it's an emotional stress that you're getting ready for the exam. You feel butterflies in your stomach. So what do you do with that? You transfer it into physical symptoms. My stomach hurts. I have a headache. My palms are sweating. All common psychosomatic or somatization things that we will see in people who experience exam anxiety. All right. So somatization is simply taking emotional stress that we don't otherwise know how to deal with, and we place it into a physical format that is more socially acceptable. So in other words, we take anxiety, and instead of getting the normal anxiety symptomologies, we get some type of physical reaction at that point. Okay. Example there, a medical or a dental student experiences a stress headache while taking an exam for which they're not prepared. All right, they felt anxiety, it gets transferred into a physical reaction. Okay, feelings of nausea when you're interviewing for, I put your residency position, this is like the postgraduate training. You could say feelings of nausea when you're interviewing for a job, your first job out of dental school. All right, maybe you want a government job and you have to go interview with the director of dental services and you feel nauseous preparing for it. Okay, developing a ringing in the ears while presenting a patient to a group of colleagues or a group of attending physicians. Okay, so these are all examples of how we take psychological issues or psychic derivatives and we transfer them into physical symptomologies. Now, perfectly normal. All right, remember we talked about this idea that it's like that line down the middle of the classroom. All right, one side is the normal use of the defense mechanisms, but if we cross over that line and we remain too far on the other side and too long on the other side, we get psychopathology. Okay, here's an example of psychopathology. Somatoform disorder comes out of this idea of somatization. So in other words, what we'll do is we'll have patients show up and they have symptoms that are very, very suggestive of a physical disease, but we have no evidence of physical disease. We run blood work, we take x-rays, we do a CT scan, and there's no evidence to suggest that there would be a physical underlying reason for the disorder. Okay, panic attacks are a form of somatoform disorder. With a panic attack, you've got an individual that essentially looks and feels like they are having a heart attack. All right, but we hook them up to an EKG and we draw laboratory values for cardiac enzymes, and we have no laboratory, we have no physiological evidence that the individual is actually having a heart attack. What have they done? They've had some type of psychological episode in their life that they just couldn't handle, and so they have a panic attack. It looks like they're having a heart attack. Okay. Now, the thing with the somatoform disorder to keep in mind if you ever encounter these individuals is we can't simply look at someone who is telling us they're having chest pain and go, oh, somatoform disorder. We have to rule out any underlying medical reason. So we have to treat the person that presents with a panic attack. We have to treat them like they're having a heart attack until we can rule out the heart attack. Then we can treat it as an actual somatoform disorder. Okay. A number of years ago, there was a really famous case in the literature of an individual who came into the emergency department. He had been the driver of a car, he had been consuming alcohol, and he had gotten into an accident. And he was responsible. And in the accident, essentially, he had killed his girlfriend that was riding in the car with him, and somebody in the car that they had impacted with had also been killed. He rolls into the ER, and he was fine. All right, they did a CT scan, they did X-rays, they confirmed that he was just fine. But then the police came to interview him about the possible charges of homicide, vehicular homicide, and all of a sudden he couldn't feel his fingers, he couldn't feel his toes, and very slowly, all right, what essentially was quadriplegia advanced up his legs and up his arms until, like I said, he was essentially quadriplegic. All right, but there was no evidence of any type of spinal compromise that would have explained this. All right, so in the end, what was the diagnosis? The diagnosis was somatoform disorder. Now, the quadriplegia eventually went away. All right, and he was actually able to stand trial for vehicular homicide. So like I said, the symptoms created by the patient, PT, their PT is patient, are physically real to them. Like I just described in this individual in the emergency department that was essentially a quadriplegic. The symptoms were very real to him. They could take a needle, they could poke his toe, and he felt no pain. All right, so just because there are no physical signs with the somatoform disorder doesn't mean that the actual disability and the symptoms created are not real for the individual. Okay. All right, so the last of the immature defense mechanisms that we need to talk about is what we call introjection, or the other term we can use is identification here. Okay, so in other words, basically you got a patient that takes the features of the external world. Okay, the institution, the hospital, the psychiatric hospital, the dental clinic, or whatever they happen to be in. Okay, that's their external world. Okay, or a person that they're working with in that external world, and essentially they internalize it. All right, they make it part of their world. Now, this is the opposite of projection. Remember, with projection, we talked about the idea that you take your internal state and you project it onto other people. So the man that is cheating on his wife feels guilt about that. He assumes that his wife is also cheating. He projects his feelings onto her. Well, here we're going to take the features of the external world and we're going to pull those into the internal world. Hence the term introjection, internalization, or identification. Okay. Now, this is normal. Okay. You do this. All right. This is part of normal social development. We learn how to act by watching our parents. We learn how to speak by watching our parents. Okay. Sometimes if you've got a kid at school that has a potty mouth, you might find that it's because the parent has a potty mouth. If you've got a kid at home that has an extremely high level of vocabulary, maybe mom and dad are both college professors, and so he's being treated like an adult. Okay, so this is normal. You're going to watch this when you get to the clinics. There's going to be specific teachers, dentists that you particularly identify with, and you're going to want to emulate their behavior, emulate the way that they interact with their students. Certain parts of my teaching style are because I have watched other professors that I particularly admire, and I have learned to identify with them. Okay. Even the way people dress. Okay, why do we dress the way we dress? Why do we dress in certain styles? It's a form of introjection in which we have seen the way the outside world acts and we internalize that. All right. So a couple of examples here. I have the language we speak is a form of introjection. Your religion, your view of the world, these are all influenced by the world around you and become part of it through the process of introjection. Okay, so here's an example here. A resident is a physician in training. A resident who attempts to emulate an attending physician he admires by emulating his bedside manner, all right, is engaging in introjection. I can remember when I worked in pathology, there was Dr. Elwine was his name, and not only was he very bright, but he was just an incredibly classy dresser. And I always used to think, wow, if I ever get to the point where I am the professor, I am the pathologist, I'm going to dress like Dr. Elwine dresses, because he's just smart and it shows in the way he dresses. Well, some 15 years later, I don't dress like Dr. Elwine. I wear Levi's and t-shirts at work. But the point is, I have internalized some of the things about Dr. Elwine that I admired. Okay. It can be bad, though. Remember, it's that fine line in the sand. We can take things about people that we like, we can take things about the world that we like, and we can internalize them, but we can also do it too much. All right? What if we have to dress and talk and walk just like the people that we admire? All right? What if our entire personality becomes wrapped up in, this is my view of what a dentist should be based upon people I've seen that I admire, and if I don't dress and act and talk and walk and interact with my patients in that exact same manner, I'm not a real dentist. All right? So there's this fine line here where some is good, all right, but too much is a problem. All right. So we have to ask ourselves, why are people doing that? Is it because they don't have any faith in themselves? Is it because they're not prepared, and so they're trying to emulate somebody that they see is an upstanding individual, all right, that is well prepared and interacts with their patients extremely well? Here's another example that might be particularly negative. Sometimes we see kids scolding themselves, and they'll scold themselves just like their parent would scold them, all right, because they've internalized that as a form of punishment. A teenager who adopts the styles or mannerisms of a popular actor or begins stalking a popular actor or an individual, that is also a form of introjection. Okay. The last one I want to talk about in terms of the immature defense mechanisms, and in particular introjection, is this idea of what we call Stockholm Syndrome. Now, Stockholm Syndrome refers generally to the relationship that we see formed between terrorists or kidnappers and the individuals that they are holding hostage. Okay, originally came out of a terrorism incident in Stockholm, Sweden, that was affiliated with a group of left-wing radicals in Europe in the 1970s, in which a group of individuals was held captive, all right, by a group of terrorists. And what they found is about 15 days into things was that the hostages, the captives, began to identify with their captors. They began to have empathy. They began to have sympathy for these individuals and for what they were trying to accomplish, so that when these individuals were ultimately rescued by the police forces, they felt bad. They felt like they had actually betrayed the hijack. They had actually betrayed their captors, and they wanted to go back into captivity with these individuals. All right, so they learned to identify with their captors through long periods of exposure and close contact with them as a form of introjection. Okay, so we've talked about the narcissistic defense mechanisms, we've talked about the immature defense mechanisms, and now we're going to talk about the anxiety defense mechanism. So this is going to be our third type. Okay. A couple of them here. We've got displacement, repression, isolation of affect, intellectualization, acting out, rationalization, reaction formation, undoing, passive-aggressive behavior, and dissociation. All right, a huge list. What are there? There's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 of them there. Okay. Remember what I said at the beginning of the lecture. Don't freak out. I'm not going to make you memorize all of them. Once again, towards the end of the semester, I'll do another YouTube video where I go through, and just like I've done with the preparation for the midterm, I'll tell you the specific ones that you need to know. So let's see if we can get these through these kind of quickly. Once again, keeping in mind that the idea is that this is, once again, it's supposed to be a slightly more mature form of defense mechanism that the individual is going to engage in here. Okay. So what do we get with displacement? Involves changing the target of your emotions, okay, or in other words, the emotions of your drives, what drives you forward, while the person who is experiencing the emotions or the drives stay the same. Let me give an example, all right, because otherwise that doesn't make a whole lot of sense, all right. Let's say you've got a man who's angry at his boss, all right. The boss didn't give him a raise. He didn't recognize him at work, okay. Can the man punch the boss? No, because that would be bad. It would get him fired and the police would come. Okay, so what does he do? He punches his desk. All right, instead of punching the boss or telling the boss how he feels. Okay, so once again, the anger is towards the boss, but he's going to take that anger towards the boss and he's going to channel it or displace it into an inanimate object that will not turn on him, isn't going to fire him, isn't going to call the police. Okay, a young doctor who's yelled at by an attending physician, all right, can he yell back at the attending physician? No, because that's going to look bad. All right, so what does he do? Well, he goes and he yells at the medical students instead. All right, so this is also known as the concept of poop flows downhill. All right, the person at the top of the hill can yell at the people lower down the hill, but the people lower down the hill can't yell at the people further up the hill. Okay, makes sense? I hope so. Okay. You might, this is another example, another common, you might have somebody who's married and they see somebody that they find particularly attractive when they're out in public. Maybe, you know, when they're in the coffee shop getting coffee or something. Well, they know that they can't go up and talk to this individual because they're already married to somebody else and they're perfectly happy married. So what do? Well, they go home and maybe they take flowers to their wife, or maybe they go home and they have some type of romantic interaction with the wife later that night. So they channel those emotions in an appropriate way back towards their wife. Okay. We see this in family therapy a lot, actually. A lot of times you'll get a family in and you'll start talking to them, and what you'll find out is that the whole family blames all of their problems on one individual. All right. Sometimes we'll see in couples therapy that the husband and wife are fighting, and the husband and wife will start saying things like, well, you know, we never fought before little Jimmy came along, so obviously it's Jimmy's fault. Is it really Jimmy's fault? No, maybe Jimmy's just a typical, 7-year-old that's causing trouble around the house like 7-year-olds do. But because the husband and the wife are uncomfortable talking to each other directly about their problems, what they do is they label Jimmy as the trouble causer. So in essence, they're looking for a scapegoat. They're looking for somebody that they can put their blame on in terms of a defense mechanism. Because once again, they're trying to banish the negative feelings that come from having difficulty in the marriage by placing their emotions directly on the child. Okay, and here I mentioned again, remember I mentioned a minute ago, poop rolls downhill. All right, displacement generally rolls downhill. We take out our frustration caused by those above us in the hierarchy on the people below us. Okay, the attending physician yells at the resident yells at the intern yells at the medical student may go yell at the nursing student. All right, something along those lines. All right, next one we need to talk about is repression. All right, basically when an idea or a feeling is eliminated from our consciousness. All right, Um, Repression is probably one of the more famous of the Freudian defense mechanisms. And basically what happens is you take a painful experience. All right. Let's say you're a child growing up in a war-torn country and you see somebody gunned down in front of you. All right. No 7-year-old should have to see grandma gunned down by the rebels. All right. That's a very negative emotional experience. So what does the child do? The child takes all of the pain associated with that, bundles it into a nice tight little ball, shoves it down deep inside of them, and does what? Forgets about it because it's too painful to think about. All right. Problem is, remember, because these are all unconscious drives that we're talking about here, the problem is the mind remembers it. The subconscious mind remembers it. And so it's still there causing psychological pain to the individual. Maybe that psychological pain becomes a form of somatization. Maybe it causes a physical pain for which no laboratory medical test can identify a cause. Okay? So it continues to cause the individual pain. The problem is they have forgotten the cause of the pain because they bundled the negative experience up into a tight little ball, shoved it deep down inside, and forgotten about them. So since they cannot remember the cause of the pain, they cannot directly confront the pain. Consequently, they can't deal with it. All right. How do we deal with this? This is a problem that we usually use psychotherapy, which is a form of talk therapy. And the idea is that over months and months of discussion about life events with a trained psychotherapist, we can finally identify what the true underlying reason is. We can remember the event. Once we remember the event, we can confront it and we can deal with it. Now, it doesn't have to be something as drastic as living in war-torn Nigeria and seeing grandma gunned down by the Hutu rebels from the north or something. It can be something in your normal life. It can be, a particularly negative breakup that you have with an individual that you cared about. Anything can be repressed. The key thing to remember with repression is that you forget the content, you forget the event, and then you forget what you forgot. So let me say that one more time. You forget and you forget what you forgot, but the psychological pain continues here. A couple of examples: a child who's abused by the mother. They're treated for the abuse, but they have no memory of the abuse. Okay, a man who survived 6 months in a concentration camp in Nazi-occupied Europe. Okay, but he doesn't remember the time period in which he was in the concentration camp. So, like I said, you forget the event and then you forget what you forgot. Now, like I said, without psychoanalysis, generally the content is simply unrecoverable. All right. In order to deal with it effectively, we need to have the individual undergo psychoanalysis. This isn't something you or I would ever do. This is something people go and get PhDs in and learn how to do. Okay. We need to differentiate this from one of the other defense mechanisms. Remember denial. Okay. Denial is that nice little impermeable bubble around the individual, but eventually we can pop the bubble. Okay. With denial, that reality was once accepted, all right, but when they go into the state of denial, they don't accept the reality anymore until we can find a way to pop the bubble, all right? And really, it's probably the most basic of all of the defense mechanisms that we see individuals engaging in. All right, let's talk about isolation of effect. Basically, what we have here is the patient accepts reality. You give them bad news, they accept the reality, they accept that they're involved in the reality, they just don't show the normal emotions. Affect simply refers to the way in which you display emotion. You see somebody you like on the street, you smile at them. Somebody tells a joke, you laugh. Somebody says something you don't like, you frown at them. All right, so it's appropriate emotional responses. With the isolation of affect, the individual doesn't give the appropriate emotion in terms of what they've been exposed to. So an abused child will talk about abuse without showing any emotion. They can talk about being beaten with a rubber hose until they bled, and they'll do it without any type of emotion. That's very common. But once again, it's a form of defense against the very negative emotions that are brought up by discussing these things. Doctors, physicians use this all the time. We'll talk about dying patients in a very bland manner. All right, 52-year-old male with advanced prostatic carcinoma, which is spread to his bones, that has 6 months to live. Why do we do that? Well, we can't become emotionally involved with every patient we deal with. That would be too emotionally damaging to them. So we use isolation of effect. Okay. Any patient who experiences a traumatic event but doesn't show the expected emotion. So in other words, we get facts without feeling here. Okay. Schizophrenics are very common. We have what we call lack of affect in our schizophrenic patients. In other words, you can tell a schizophrenic patient, hey, your mom just died, and they'll stare right through you like they didn't even hear the news. Schizophrenia is a very interesting psychiatric disorder. We'll talk more about that in the last lecture semester. Intellectualization, a very common one as well. Okay, basically, what do we have here? It says, results when affect, remember, our normal emotions are stripped away and replaced with excessive use of the intellectual process to explain an anxiety-provoking situation. Okay, so this might be, if I take a physician and I sit them down, and it's a colleague of mine, and I give them the diagnosis that they have prostate cancer. All right. The man sitting across from me is a highly intelligent individual. He understands what prostate cancer is. He understands what a diagnosis of it is. He understands what it means in terms of treatment. So rather than breaking down in tears and going, oh my gosh, I have prostate cancer, but I have a wife and children. I want to see my kids grow up. I want to have grandkids. They intellectualize it. They start talking about, I see, doctor. Well, what stage is my prostate cancer? And if I were treating myself, I would recommend that we start with radiotherapy and possibly a 2-month dosage of chemotherapy to go with it. Do you see what they're doing? They're taking away the emotion, and they're replacing the emotion with their intellectual understanding of what is going on there. So there's an example of that you can read. Okay. Here's another example. A man who's scared to ask his girlfriend to marry him does what? He starts talking to her about, marriage rituals are good for long-term survival of the species. So maybe if you and I got married, we would have we would live longer. Yeah, that's it. So he replaces the emotions with the intellectualization. Do any of you watch Big Bang Theory? Dr. Sheldon Cooper is the king of intellectualization. In the last 2 seasons of the show, they've actually allowed him to have a girlfriend. But rather than him engaging in normal conversation with his girlfriend, he intellectualizes everything. So that's a perfect example of that as well. Okay. Any type of a practitioner that focuses solely on the technical aspects of treatment and ignores the emotions of their patient because they're trying to protect themselves from getting too emotionally involved with their patients and hence hurt, that's a form of intellectualization. Our OCD patients, our obsessive compulsive patients, are using intellectualization as a way of explaining their behavior. The man who flips the light switch on and off 50 times before leaving the house doesn't really believe that that's going to keep the house from burning down. But it's an obsession that they have, and they can't explain it away. They say, well, if I flip the light switch on and off 50 times before I leave the house, I realize that's obsessive, but it helps relieve the anxiety associated with me leaving the house as a form of intellectualization. Okay? All right. Acting out is our next type of anxiety defense. Basically, it results when a massive emotional or behavioral outburst is used to cover up the underlying feelings. So in other words, the acting out does not display the real emotion, but it covers it up. Think about a child who throws a temper tantrum. Maybe his dad leaves the family. Maybe dad runs off and abandons the family, and one day standing in the middle of the grocery store, Junior throws a fit and knocks 2 bottles of pickles off the shelf. All right? Is he mad that he didn't get the pickles? No, what he's really mad about is that dad's gone. And maybe he's being teased about that at school. Maybe he just wants his dad to come home. So he acts out as a way of channeling otherwise unacceptable emotions into some type of a physical act. Okay. Once again, this can be common. In adolescence, alcohol and substance abuse is a form of acting out. It's a way of finding independence. It's a way of combating the feelings of not belonging to a particular group, for instance. Unsafe sexual practices among people who have HIV are in many ways a form of acting out because it covers up some type of underlying feeling of vulnerability. Okay. Don't worry about that comment there about ADHD. It's really not practical for what you guys are learning. Okay, so it's differentiated from displacement in that the emotion is covered up, not simply redirected. Okay, what about rationalization? Results when patients use rational explanations to justify their attitudes, beliefs, or behaviors that are otherwise simply unacceptable. Okay, the example that we have here, and it's a very common one, is you'll see people that will engage in oral sex. All right, and they will say, well, it's not sex, it's oral sex. All right, so I'm not engaging in any type of inappropriate behavior. They rationalize what they're doing because otherwise they feel bad about the behavior. A person who states that they believe killing is wrong, all right, but they kill another person because they believe that person was bad or that they deserve to die. There's a TV show called Dexter about a detective that goes around. I mean, maybe he's not even a detective, but he goes around and he solves crimes and he kills these people in the end. And he rationalizes the act of killing these individuals by saying they were bad people. They deserve to die. All right. So generally, it's not an excuse to initially engage in the action, but it's an afterthought to rationalize the behavior that they engaged in. Once again, it's a form of relieving the anxiety about the behavior that they engaged in that otherwise would be wrong. Okay. The same thing. OCD patients will also use this. They'll say, well, I know that flipping the light switch on and off 100 times is not going to keep the house from burning down, but I do it as a form of helping control my anxiety. All right. Reaction formation results when an unacceptable impulse is transformed into its opposite. So we get a complete global reversal of emotions. Let me give you an example to explain this. All right. So in the U.S., students go to medical school, and then when you're done with medical school, you have to compete to get into training to be a surgeon, training to be a family doctor, training to be a pediatrician, training to be whatever it happens to be. And certain specialties are very, very competitive. Only the best of the best become ophthalmologists or dermatologists in the United States, for example. So you might take a medical student that his whole undergraduate career, his whole medical school career, he said, I want to be a dermatologist. That's what I'm going to be when I grow up, okay? And maybe he doesn't get the greatest grades. Maybe he doesn't do quite as well in the board exams as he would like to do. And he finds out he's not going to be a dermatologist. He finds out he's going to be a family doctor. Well, inside, he is emotionally distraught. He's emotionally destroyed by this. But because he doesn't want to show those emotions, he doesn't want to show weakness, and he doesn't want to display those things, he uses reaction formation. He goes, this is the greatest news ever. I didn't really want to be a dermatologist and look at pimples all day. I wanted to be an internist and give fat people diuretics to treat their hypertension and anti-cholesterol drugs all day. So we get the opposite reaction to hide the negative emotions that are associated with it. Okay. Another example might be you see little kids on the playground, and one of them walks up and punches the other one. All right, and you'll say, Johnny, why'd you do that? And later you get Johnny to admit, well, I did that because I like him. All right, and that's the only way that little Johnny knows how to show the emotions. You see two teenagers that bicker and fight in a class, and it turns out they really like each other. All right. Right now, my oldest son, there's some girls at school that are particularly mean to him, and I've laughed and I've said, well, Alec, have you ever considered they really like you and they just don't know how to go about telling you that? That would be a reaction formation. Okay. Excessive overreaction would be a sign of reaction formation as well. Okay, why? Because the person is basically not only trying to convince those around them that these are real emotions, but they're trying to convince themselves. Okay, we find this a lot in anxiety disorders, or we find it also in social anxiety disorders as well. Okay. Undoing, all right, is a situation in which a patient acts out the reverse of an unacceptable behavior to repair or fix an inappropriate impulse. Let me give you an example here, okay? A man who is sexually attractive to a woman at work or someone that he meets on a bus or something, what does he do? He can't act on those emotions. So what does he do? He goes, he buys his wife flowers, all right, to try to undo the negative emotions. If you belong to some form of an organized religion, repentance is a form of undoing. So we all know that all religions have certain things that are prohibited. All right. My religion prohibits me from drinking alcohol. If I drink alcohol, though, I can go and see the appropriate authorities within my church, and I can repent of that behavior. I can undo that behavior and be forgiven by both my church leaders and, in my mind, also be forgiven by my God. All right. So that I can banish those negative emotions that came about by engaging in a negative behavior. A man that's a recovering alcoholic goes to a bar, buys a drink, all right, but he doesn't drink the alcohol. He immediately leaves and he goes and he calls a friend from Alcoholics Anonymous and says, hey, I'm tempted to drink the alcohol. Can you come over and help me not drink the alcohol? That is also a form of undoing there, okay? We mentioned the religious one there. In OCD, a lot of times you'll see people with OCD, they'll obsessively wash their hands because they have a fear of germs, okay? That's a form of undoing because the individual is trying to deal with inappropriate fears by engaging in a ritualistic behavior, okay? Passive-aggressive is also going to be one of our anxiety defenses, okay, in which the individual does not perform a behavior action after they have set up the expectations of performance. So in other words, an example here is somebody isn't going to be in class. All right, and you know they're not going to be in class, not because they have a doctor's appointment or because they need to meet with their advisor. You know they're not going to be in class because they want to go down to MHCC and have lunch with their boyfriend. Okay, and so they say to you, hey, will you do me a favor? Will you take notes for me? And you go, yeah, I'll take notes for you. And you fully well understand that in truth, you're probably not going to take the notes for them. All right. So that's passive-aggressive. A physician who ignores patients' direct questions, all right, because they find the patient annoying. That's a form of passive-aggressive behavior, okay? So the passive behavior in which the individual fails to perform is regarded as aggressive by the other individual. So you're passive. You say you'll take the notes, but you don't take the notes, all right? And the other individual who wanted you to take the notes views that as aggressive behavior on your part, okay? Let's see, we've covered all of that, all right? Common in borderline personality disorder patients, but don't worry. Let's go ahead and we're going to pause right there. I will upload this group, all right? And then we will move on and we will, in a third presentation, part C, we'll talk about the mature defense mechanisms. So in other words, the defense mechanisms that are supposed to be utilized by those of us who are mature, intelligent, thinking adults. And then the good news is that's the last of the defense mechanisms. So the lecture is almost over. All right,